morning, everyone. The breakfast is going to continue to be available until about 10 a.m., but we're going to go ahead and get the program started. All right. I have a few housekeeping before we begin. I want to remind everyone, we know it's a long walk. So I do have to once more acknowledge what they've done for us, for this community. So I want to just go through that list once more, and at the end I hope you will join me in a round of applause to them and thanking them for their support. So we have our super sponsor, Lundbeck, and they have been our friend for years. We have one of our new sponsors at the diamond level, and that is Biohaven, and we're looking forward to a continuing partnership with them. We have our old friends at again, could not do it without. So thank you very much to these generous companies and nonprofits that have assisted us. So today we're staying in one place. We're staying in this room, but we've got some nice breaks built in and some snacks throughout this morning and afternoon. And today we're focusing on the medical and the research. So as we begin this morning's program, Dr. McFarland is going to return to the podium in just a moment and lead a panel that he has put together with a few of our colleagues from the board. And we're going to have a moderator, and that's going to be Dr. Allison Mayu. And I want to just say Dr. Allison Mayu is a member of the MSA Coalition Board of Directors. I'm sure many of you have met Allison. She's been running around like crazy helping. And she came to this board and got involved in the coalition through her journey with MSA with her brother, who she lost several years ago. So we thought, given her close connection to MSA and her medical knowledge, she would be the perfect person to moderate this panel and guide our discussions. In a little while, some index cards will be passed around. Throughout the medical presentations, we encourage you to jot down your questions. We're not doing Q&A during their presentations. We are doing them afterwards, which has always worked out well. So what will happen is after the presentations, there'll be a short break, and then we'll go around and collect your cards. And after the break, then we will have an opportunity for questions and answers. So your questions will be heard, and the panel will have a chance to speak to those things that you want to learn about. All right, so the index cards will be coming, but meanwhile, you do have pads on the table as well. Okay? So I'm going to go ahead and turn this over to Dr. Mayu, who's going to come on up and lead this morning discussion on the medical aspects of treating multiple system atrophy. Allison?
Good morning, everybody. We have an outstanding panel that I think will make a lot of presentations that you will find very important in your journey for MSA, with neurologists, a gastroenterologist, urologist, et cetera, that have a lot of knowledge and expertise in dealing with patients with autonomic disorders and multiple system atrophy. So I hope you'll take in and write plenty of questions, because the question and answer session after the break is going to be, there's a generous amount of time for those questions, and I encourage you to ask anything. There are no stupid questions, I promise you. Our host, our generous host, Dr. Nikolaus McFarland, is from the University of Florida. He is the Associate Professor of Neurology and the current Chief of the Movement Disorder Clinic at the University of Florida College of Medicine. He'll be joined by Dr. Ramón Rodriguez, who is a former UF faculty member in neurology, and he is now the Medical Director of Neurology 1. Dr. Tom Chelimsky is a neurologist at the Medical College of Wisconsin, and he actually hosted the first conference I went to in 2013, which was held in Milwaukee. He has been a longtime supporter of the MSA Coalition and a longtime board member, and we value his involvement with our group. Dr. Amaris is Director of the Motility Program, Division of GI and Hepatology and Nutrition at the University of Florida. And Dr. Louis Moy is an Associate Professor in Urology at University of Florida College of Medicine. So I hope that you'll enjoy and pay close attention and write down your questions all throughout the presentations. I think you're going to enjoy this morning's presentations. And I'll turn it over to Dr. McFarland now. Thank you.
Let's see how we work this. I'm gonna lay this down. That's me. Oh, hey. All right. Good morning, you all. How is everybody? All right. After last night, I was wondering about it. We had such a great time last night. I want to give a shout out to our organizers again, Cindy and everybody from MSA Coalition. This has been a wonderful event so far. And last night's event was par excellence, really. A lot of fun. So hope everyone got a good sleep after that show last night. We're looking forward to a really great day today. It's going to be a little bit long day. We will try to keep our talks relatively short and try to moderate things. We want to give you as much information as possible about MSA today. We've got a great lineup for you. Hopefully this session will be finished within about an hour or so, and then we'll get a time to stand up, and then all of us will come up here for questions. Really, there are no stupid questions except for the one you didn't ask us. Feel free to challenge us. We want to answer your questions and do all we can to help out here. That's what we're here for today. Okay? So the plan that I had to do for today was I was going to start off this session by giving a bit of an overview for MSA, and I'm going to let each of my colleagues here, my esteemed colleagues, today. This is the list of all their names here. So as you mentioned, Dr. Rodriguez and I worked together for a while at the University of Florida until he decided to come down to Orlando and start his own business here. He's done a fantastic job and is really well knowledgeable. Dr. Chelimsky, I don't need to really introduce you, is on the board, has been involved with this MSA Coalition for many years. And I was able to get a few other folks here. The only person on this list that you won't be able to see today is Dr. Holly Skinner. She also was a faculty member at the University of Florida. But now she works here at Advent Health, here in Orlando. She is a sleep medicine neurologist, okay? She generously provided slides for today. I'm going to pinch hit for her today and do my very best. We all have pretty much a lot of experience with sleep issues and multiple system atrophies, but I'm going to step in for her and give her talk, but she generously provided that for you all. All right, so with that said, let me just start off with an overview of MSA, and I'm going to cover a little bit of what folks are talking about today, but I want to at least just sort of give you an outline for MSA. I know many of you know what it is because you're experiencing it, but as a neurologist, I think one of the first things people often ask me when they come into my clinic is they were told they were diagnosed with what's called Parkinsonism. Okay, so, you know, Parkinsonism is this, it's really more of a descriptive term, a constellation of symptoms that patients often have. Typically, we think of this acronym TRAP. So tremor, typically a resting tremor, and Parkinsonism we call rigidity or stiffness, slowed movement. Actually, the most severe form is we call lack of movement, as well as postural instability or problems with falling. Okay, those are the constellation of features we see in Parkinsonism. One of the key features is really slowed movement. Okay, sort of stuck in jello. All right, those slow movements. There are many things that actually cause those symptoms. Okay. By far the most common symptom is actually Parkinson's disease, and I list that over here on that slide, shown over here on the left-hand side, okay? So as a neurologist view, this is my view when you guys come into our clinic. MSA is down below, okay? But I want you to just recognize really here that this is the conundrum, and I'm sure all of you, you know, when I see patients in my clinic, often it might be the third, fourth, or fifth neurologist, and I really like to see that sort of decrease. Obviously, those of you have probably experienced that problem with MSA and getting an early diagnosis. So, but this is really the conundrum for neurologists when we see patients is what is it, okay? There are what we call secondary causes. This is our job to figure out that. What I mean by secondary causes is things like drugs and stroke, vascular things like that. And there's a whole list of things on that left-hand side shown here. Let me see if there's is there a pointer? Let's see. Yeah, there we go. There are a bunch of genetic or hereditary causes of Parkinsonism as well that can mimic the symptoms of Parkinson's disease or Parkinson's-like symptoms. And then these atypical Parkinson's disorders. So multiple system atrophy fits into this atypical Parkinson's group. But as you notice, there are several other different atypical Parkinson's disorders. And it's really our job to help you kind of figure this out, okay? I will also point out here that more and more when patients come to our clinics, we are starting to think about what's called the clinical and the pathological features of disease. So back in my mind, I'm kind of thinking, okay, what's going on in that brain of yours? And these are sort of what we're looking at. So Parkinson's disease and many of the Parkinson's disorders are commonly feature a pathology that's called synuclein. So this is a protein pathology. So what's common among all these disorders really is this abnormal protein accumulation in the brain, often in neurons, but also now seen in other supporting cells too. It's common in diseases ranging from Alzheimer's disease to ALS, all the way to Parkinson's disease and multiple system atrophy. This is important, okay? And it will become increasingly important because we're starting to move from what we call symptomatic disease therapies to things we call disease-modifying therapies, DMTs, okay? Disease-modifying therapies. And these things are starting to target things that are going on in the brain, okay? This is the goal, okay? We're all kind of thinking about how are we going to slow this disease down and if possible, even reverse it. And then that sort of four-letter word that I hate to say, but cure. But I'm really hoping for that. But this is why this is critically important. And you may hear us talk about things called synucleinopathies or tauopathy disorders, because we're starting to think about what's going on in your brain more than just sort of the diagnosis, okay? So I just want to raise that here, and we'll bring the pathology in. And later this afternoon, you're going to hear from the researchers here and the scientists that are actually working on this, and you'll see how relevant this really is, okay? But hopefully your docs are thinking this way as well, okay? So one of the big questions really is, that I see in the clinic is really, is it MSA, okay? Is it Parkinson's disease? And so what are those features really that I'm looking for, okay? So There are a number of red flags, okay, that are available for us. So like early problems with gait and balance. Typically, Parkinson's patients actually have this shuffling, slow gait, but they don't really start falling frequently until about 5 years in disease or actually later. With MSA or atypical Parkinson's, this occurs much earlier. Prominent speech or swallow issues, okay? Yeah, Parkinson's disease, we see patients who have sort of this monotone, slow speech, but the type of speech in MSA you'll hear is much different, okay? Could be much more slurred, could be much more effortful, can actually have a little bit of variability in it as well. It's not the same that we see in that disease. Swallow problems, while present in many Parkinson's disorders, are much more a problem in multiple system atrophy and other atypical disorders as well. Is the presentation symmetric or asymmetric? So you may have heard that most Parkinson's patients typically present with one side affected more than the other side. In atypical disorders, sometimes the presentation is affected both sides, so a little bit more symmetric as well. There may be, we call spasticity or other track signs that a neurologist may detect on you. And then, sort of last but not leastly really, frequently we try drugs to treat Parkinson's disorders, and the most common one, or the gold standard drug, is levodopa or L-DOPA, listed here. And it's this poor response that often leads to referral to our clinics to ask, is this Parkinson's disease or not? I will tell you that most Parkinson's disease patients get a good response. MSA, you may get an initial response, but that response wanes quickly, or it may cause side effects and not be responsive. But I will tell you that even in Parkinson's disease patients, not all patients respond to levodopa. So it's not, it's not an automatic sort of thing saying, just because I don't respond to the drug, that doesn't mean you have MSA, okay? There are other features that we need to look at, and those are these sort of plus features. So in the past, we used to refer to these atypical Parkinson's disorders as Parkinson's plus disorders. So Parkinsonism, those constellation of features plus different things, for instance, eye movement problems, problems with sort of learned behaviors or early dementia, that can sort of be clues to a neurologist or a physician that maybe this really isn't just classic Parkinson's disease. One of the key features in multiple system atrophy, and I'll come back to this really, is this we call autonomic features. So the automatic nervous system, things that control things like bowel function, sexual function, urinary function, blood pressure control, and it's just part of the top of the list, okay? And you'll hear more about that later today, can be really clues. So I wanted to give you this little bit of overview here before we go into MSA and specifics, okay? But these are the clues that we use to kind of think, is this something else, okay? I mean, this is really important. So I'm going to jump right into multiple system atrophy. So what really is it, okay? It is one of the most common forms of atypical Parkinsonism. I show sort of an instance and prevalence shown here. In the United States alone, we have about 1 million, well, probably more than 1 million Parkinson's disease patients. So the difference you can see here, we're talking about 20 to 40,000 patients. So much less prevalent, but still a fairly common atypical Parkinson's disorder, okay, defined. Onset's typically in the 50s, so roughly, on average, the median is roughly around 58, okay? And it comes in different forms. So I like to talk to my patients, and I think so many of you, some of you have heard me talk about MSA as having multiple faces, okay? It went by different names earlier on, so historically, you'll see here listed on here these old names, okay? Shy-Drager. This one maybe people haven't heard so much, but striatal degeneration. And lastly, olivopontocerebellar atrophy, okay? These are still terms that are used, but sort of these are older terms. Now we kind of refer to these diseases all as multiple system atrophy. It has a few different phenotypes. So phenotype's the way it presents, okay? And those phenotypes are either predominantly Parkinson's, okay? Parkinson's meaning, so this Shy-Drager and striatal degeneration presents often with a predominant Parkinson's phenotype. And it very much overlaps Parkinson's disease, particularly early on in disease, and can be difficult to distinguish there. The key features really here is for this is the association with autonomic symptoms, okay? Things like orthostasis, which is postural hypotension, okay? So you're standing up, you get low blood pressures, or even labile blood pressures, can be urinary issues. The other key feature here is sort of more rapid progression. Lastly, there's also this, we call a cerebellar phenotype. So cerebellum is that thing that hangs off the back of your head that helps with coordination of movement and behavior, okay? Patients who have this type of disease actually present often with predominant problems with coordination, balance, speech, often may present sort of like a drunk-like sort of speech and walking, okay? There can be overlapping features. I'm going to talk about these each in detail. But the key here was this was sort of named olivopontocerebellar atrophy based on the imaging findings that we see, and I'll show you a picture of that in just a second here. So why are these all now lumped together into multiple system atrophy? Well, it's because, coming back to that clinical pathological issue, we've learned about the pathology, okay? And the pathology really is this thing here on the right-hand side. This is something you cannot see on an MRI, okay? This is a neuropathological feature that we see. These are actually cells in the brain that contain what are called Lewy bodies, okay? These are protein deposits within a cell that are abnormal, okay? And in multiple system atrophy, these deposits are most frequently found in not the neurons, but the supporting cells we call glial cells. And actually, they were originally called glial cytoplasmic inclusions. Okay, so these protein deposits you can think of as sort of, it's a wastebasket in the cell and it gets really large and full. The cell cannot take the trash out anymore, okay? And you imagine if the trash builds up in your house and you can't get the trashman to take it out, your house is not going to function. The same thing happens in a cell. It doesn't function right, okay? And this leads to degeneration in the brain, okay? So this is a common feature in all of these diseases, so hence we went back and called them multiple system atrophy together. But again, to just point out the different phenotypes. So I'm going to just kind of go over a little bit about the Parkinson's type and give you sort of some features here. Sort of the balance of sort of features that we see here. Parkinson's disease patients have sort of this hypophonic speech. They have a tremor, asymmetric presentation. I mentioned that sort of more symmetric kind of features of sort of their tremor here. You may see all these autonomic symptoms, more spastic, sort of different kind of speech features earlier on. The tremor in multiple system atrophy sometimes looks different than Parkinson's disease as well. Instead of a pill-rolling tremor, sometimes it could be sort of a mixed tremor, both sort of postural as well as even at rest, and sometimes it has this higher frequency and a jerky quality to it as well. There are a bunch of other features that we see in multiple system atrophy that give us clues as physicians to this disease. You'll hear a lot about speech issues, you'll hear a lot about sleep issues in this disease. There may be, we call dystonic features. These are features where you get pulling of muscles, and it may lead to either pulling muscles in the limbs as well as the neck and the trunk, making you either lean forward like a dropped head, okay? These early falls here. I'll point you out at the bottom here. A couple other key features are these issues that I've mentioned already. The presence of autonomic symptoms, or symptoms that affect the automatic nervous systems, are much more frequent in this. They're not absent in Parkinson's disease. They're still common there, but the comparison here, much more frequent and much more severe frequently. Levodopa in patients does help, but over time starts to fail. For many patients, and in some patients actually you can see a specific type of side effects which are called abnormal movements, dyskinesias. They could be oral facial kind of dyskinesias that we see sometimes, or it could lead to confusion, or in some cases just exacerbate the blood pressure or other issues that are in patients, okay? Key here listed really is this poor, sometimes unsustained response to drugs. That can be sort of a clue. The main clue really here is this progression, okay? With many patients, I think as you've seen here, the progression is different than Parkinson's disease. If you've been in a support group with PD, you may start to see that, okay, I'm not progressing the same way. My symptoms are much more severe to the guy who's got Parkinson's disease. I'm already in a wheelchair. Why is that person not? That's because of this more rapid progression, okay? So let me say just a few words about this cerebellar type, or we call multiple system atrophy C. So most often this is a sporadic disease, okay? A bit closer to a equal male to female predominance. The onset is somewhat more variable. You can have both the cerebellar features as well as Parkinson's mixed in there. There are other features that people see in this disease, eye impairment, movements. You can have those other autonomic symptoms as well. You can have even some progressive memory and thinking problems, or we call dementia. Emotional lability can be seen too as well in this patient population. What we have to kind of distinguish here really is that there are, just like with the Parkinson's, there are many things that cause Parkinson's features. There are many things also that cause ataxia or cerebellar features too. There are many ataxic disorders. If there is a family history, We have to rule out familial forms of ataxia. There's a whole bunch of different, versions of genetic ataxias that we rule out. There's even inflammatory autoimmune types of ataxias as well that we have to rule out too. So it's important to kind of look at that. So what are some of the things that we can do besides doing an exam? So the key thing really is history and exam. There are some ancillary tests that we sometimes use to help to distinguish these, and we're going to talk a little bit about that. Dr. Chelimsky is going to talk a little bit about autonomic testing. So some of the tests listed here, like the tilt table test, thermoregulatory sweat testing. I'm going to talk more about sleep studies. So sleep can be very much a challenge in this disorder, and there are multiple problems with sleep. The quality can be affected. People can have sleep apnea, stridor. We'll talk more about this thing called REM sleep behavior disorder, which is common in Parkinson's, and we call synuclein pathology disorders, which MSA fits into, and other features. And then lastly, one of the most common thing we do is get brain imaging, and this can be helpful in some cases, but is primarily supportive, not necessarily always diagnostic, okay? So these are tests that we use. Here's just an example of imaging findings that we see in some patients. This is a more severe feature. Hard to see these sometimes early on, but sometimes we see atrophy within the parts of the brain called the basal ganglia, shown here. So these are parts of the basal ganglia, and we see sort of shrinkage of a part of the brain we call the caudate and putamen in particular. And sometimes we can see this shrinkage, and we can even see a slit, sort of hyperintense sort of sign next to the brain in this particular area. Pathologically, I think Dr. Nes-Dixon may talk to you about this as well. We see a significant degeneration of this part of the brain too. In patients that have this olivopontocerebellar atrophy, we look at this part of the brain. This is the cerebellum that hangs off the back of the brain, this part of the brain here. Hey, sort of, I've oriented you guys. This is the nose, this is the back of the head, top of the head. This is sort of a middle view of the brain shown here. So what you see is the higher brain, you see the brainstem here on the cerebellum. This is a cerebellum that looks relatively small. There's also this part of the brain we call the pons. So we call that pontine, shows atrophy or shrinkage as well. And on the other side here, this is just a slice through this portion of the brain, right down here. We can see shrinkage of this part of the brain. So that's why it was named sort of olivopontocerebellar atrophy. And sometimes we actually see a characteristic sort of gliosis in the pons, actually, this sort of scarring that kind of gives this sort of hot cross bun sign. This is seen later on. It's not always seen in patients, but these are some of the clues that we use as clinicians to figure out, is this MSA? Okay. They're not always diagnostic. This can be seen in other disorders, but these are some of the clues that we use. Okay. So I wanted to just give a brief overview. I'm going to rely on my partner here, Dr. Rodriguez, to kind of go over a little bit more of the treatments, but just as an overview, how do we approach multiple system atrophy? Well, it's a multidisciplinary approach, first of all. I'm going to come back to that. It takes a team, so I don't do it all by myself. The treatment, likewise, is multi-symptomatic, okay, in terms of treatment. So taking the different aims, so for instance, the Parkinson's part, I mentioned that a lot of people get put on Parkinson's medications. So the most common one is levodopa. Most patients should get a trial of levodopa, okay? And what by that really, with a dose trial should be an adequate dose trial as best as possible. Frequently we see patients who get a trial of maybe 1 tab of levodopa 3 times a day, and that's it, and they get taken off. That's probably inadequate. We like to see patients pushed on the dose to see if it actually really helps them. So getting an adequate trial can be really important. Some other medications can be used, and I think we'll talk more about those as well. But different medications for this disease can also cause side effects. So one of the key problems is really that blood pressure, those automatic nervous system things. So coming to that, okay, there's treatments for the autonomic symptoms, for instance, the low blood pressures that people have. There's some conservative treatments, and you'll hear us talk about some of these medications, everything from fludrocortisone to midodrine and droxidopa for, moderating blood pressure. Gastrointestinal symptoms. So Dr. Amaris is going to talk a little bit about this today and go into constipation, gastroparesis. There are multiple problems, as you all know. And then urinary function. So Dr. Moy is going to discuss issues there as well. Urological evaluations are very important in patients who have urologic problems. And there are ways that we can treat some of these issues for patients as well. And then last thing, I'm going to go over sort of the sleep issues and potential treatments for sleep issues. Sleep apnea needs to be evaluated. Stridor is a big issue. So stridor is that gasping for breath that can occur, can be very severe, okay? It needs to be treated. And then this thing that we call REM sleep behavior disorder or dream enactment. that can be quite violent, actually. Hurt your partner as well as yourself, falling out of bed and injuring needs to be treated too, and there are things that we can do to treat that, for instance, melatonin versus clonazepam, and we'll talk about that today. I do want to take a few minutes to sort of emphasize, again, multidisciplinary treatment is really key for this disorder, okay? That's why we brought our team here, and I think many of you recognize this. It really takes a team to treat this disease. No matter how many medications I can talk about, without physical occupational therapists, without speech pathologists who help you with your speech and swallowing issues, we really couldn't treat this disorder well. It's really important to have nursing and social services as well for this disease. So these are all the key team players that we have that are really necessary. I do want to just take a brief mention to talk about palliative care as part of the team too, okay? Palliative care is treatment that's directed at comfort, okay? It's not just hospice, okay? And I listed a few things here actually to talk about. So this is focusing on comfort and quality of life, okay? Treating pain and suffering, your well-being, these are all important things, okay? Spirituality, into life, how do you end your life on your own terms, okay? Clearly hospice is part of this. I do want to mention here, this is not about giving up, okay? It's not about getting rid of your doctor. I stay part of patients to the end as a physician. All right, this is really trying to help you for a disease where we have to talk frankly, really. This is a progressive disease, okay, that we don't have a cure yet for. We're really working hard on that, but we have to take care of our patients from beginning to end. And I think it is important, and to do it on our terms is really important. But I want you to know this is really part of that, okay. Lastly, I want to just mention sort of where the hope really lies here in this disease. The amount of research in MSA has exploded, and this is just sort of a basic overview, okay? I like to talk about sort of bins. So there are sort of 3 bins of research that I want people to understand about, and I'm not going to really have a lot of research talk this afternoon. But the 3 bins really are 1 for symptomatic treatment, 2 for treatment that will either slow the disease, okay, or stop it in its tracks, okay, and then 3, that third bin we call the cure, okay. We're actually not doing so well in all of these bins, okay? Symptomatic therapy has been limited largely to the Parkinson's part and this part, the orthostatic hypotension stuff, okay? We have some other treatments we're going to talk about today, but we need a lot more research in that area. This second bin, slowing down disease, we call disease-modifying therapies. We've made some progress, so that's really hopeful, okay? And I'm just going to show you a few things here, okay? So listed on here is just some examples of where we're at. This is an amazing slide, actually, to me. There are a lot of new drugs that are actually out there that are being tried for symptomatic orthostatic hypotension. These are the disease-modifying therapies. They range they range from basically IVIG to sort of stem cell therapies that many have asked about. There are a bunch of drugs that are sort of in the experimental phase listed here, and there are a whole bunch of medications that are still being looked at in the lab, okay? So there's a lot of things coming up. So I know people are interested in trials and they want to be in them now, but just understand there are more coming right behind that. So this is a very hopeful time for MSA patients, okay? I don't have time to go through each one of these, but I just wanted you to notice the different mechanisms that people are actually targeting this disease for each one of these different treatments, okay? They all act on different parts of the brain and different parts of the system of the body to actually help treatment, okay? So I wanted to give you this overview. I hope that was helpful. We're going to go into each one of these in detail briefly, okay? This is our clinic, so thank you very much for your time, and we'll have questions in. We're all going to kind of join, so each of us will give a talk. We'll kind of join at the panel right after the break, and you guys, please write your questions down. We'll take them at the end here. We'll collect everything, and then we'll try to answer all of them together, okay? Thanks very much. All right, so I'm going to ask Dr. Rodriguez, my colleague here, to join me up. Yeah, I do this one.
Alrighty, well, that was a great summary, Nick. I appreciate that. So what I'm going to be doing today is I'm going to be talking a little bit about how do we treat patients with multiple system atrophy? Over the years, there has been a large frustration because always doctors might tell patients, you know what, there's no treatment, go home, you don't have to come back. You know, they paint a very dim outlook about the condition. However, you know, just like runners run, fighters fight, right? And people with MSA, they're fighters. We give the fight and we try to do everything we can. And I have learned many things over the years. You know, my specialty as a movement disorder specialty was always advanced Parkinson's disease. So surgery for Parkinson's disease, infusion therapies for Parkinson's. And because I was doing that kind of job, I used to have a lot of patients with multiple system atrophy that ended up coming, and they ended up coming because, you know what, I'm not having that great benefit from the medication. I think that I need one of these other procedures. And in fact, after reviewing the symptoms, turned out that the patient had multiple system atrophy. So at that point, we will do the proper diagnosis for the patient, and we will tell them, listen, this is how we're going to attack this condition. So pay attention to me. We're going to do this. You have to play the game and follow my advice. So that's what I'm going to be talking a little bit about today. So in first place, I have to say that no two patients with MSA look alike. And even so, as we have patients with the Shy-Drager symptom side or type, or the autonomic insufficiency, the cerebellar type, or the Parkinsonian type, you see that even under the same name of the condition, there can be multiple varieties. So obviously, we have to sit down with the patient. We try to determine what type of MSA they have, and then we come up with a plan of action. But there are some symptoms that tend to be the most common in this population. So number one, stiffness, and stiffness means rigidity, slowness, or bradykinesia. Almost every patient, if not every patient with MSA, will be slower than usual. You know, patients, family members typically say, you know what, Pop is taking longer to get dressed and getting ready for church on Sundays. That kind of comment. So that gives us a little bit of an idea about what is happening. Tremors. And some tremors look a lot like Parkinson's disease. And you know what? When you have a tremor that looks a lot like Parkinson's, it makes it very difficult to differentiate one type versus the other. And in my impression is that, there is a continuum. There's a line, right? And depending where you are on that line is the type of symptoms that you're going to present. Balance problems. This is very frustrating, and almost every patient will have some sort of balance issues. And with these balance issues, I'm adding the issue of the postural instability, which is the sensation of that the patient is going to faint or pass out after they're standing up. Laryngeal stridor. I tried to download a video that I have from a patient, but then he revoked consent. So I wanted to show you how this looks like. Dystonia. Dystonia is an involuntary contraction of the muscles. And I'm going to tell you a little bit about this regarding the dystonia and the head as well. Gait disturbance, problems walking, and then dyskinesias. Dyskinesias are just abnormal involuntary movements. I'll tell you how they typically look, okay? Now, when we talk about MSA and whether we should be treating patients, the truth is that 30 to 40% of patients with MSA will respond to levodopa. And levodopa, be aware of this. Levodopa is a naturally occurring amino acid. Okay, so there are many things in nature that are high on levodopa, faba beans, mucuna. There are some other plants that are rich on levodopa. So I tell my patients, listen, do not be scared. Just like if you eat a big cake, you're going to get sick. If you have too much levodopa, you're going to get sick. But if you eat a small slice of the cake, you're going to enjoy it and you're going to do fine. At the right amount of levodopa, you might be able to get some benefit and do well, okay? The other thing is that patients on levodopa typically show a fairly good response, usually within the first 5 years. After the 5 years mark, it is usually during that time that patients might start losing that benefit. So be aware of this, and this is typically when the patient will go to the doctor and will say, you know what, I'm not responding as well to my medication. The benefit might not have been dramatic, but at least was something. But usually during that time, they might lose the benefit, and the patient ends up going to the doctor. And this is when the doctor will say, you know what, I think that this is looking more on the MSA side compared to the Parkinson's disease side. So let's sit down, let's talk about this, okay? So levodopa levodopa is generally well tolerated. However, some people will have an exacerbation of the orthostatic hypotension, and that is going to be the limiting factor typically for patients on levodopa. We have to recognize that some patients on the levodopa might develop some dyskinesias, and the dyskinesias in people with MSA are typically in the face. There's a lot of grimacing in the face when they take their levodopa. And this is a dyskinesia, and if this is happening, you will go to the doctor, and the doctor will look at it. And even myself as a doctor, when I have a patient with a lot of facial dyskinesias and not a robust benefit to the levodopa, it's actually something that raises a flag that I may be dealing with a patient with multiple system atrophy. The response to the medication can be unique for each person. So for example, Mrs. Williams might have improvement of her rigidity. Mr. Thomas might have some improvement on the tremor, and Mrs. Stevens will have some improvement when she's walking. And when I say improvement, it might not be that the patient is walking back to normal, but if they were going to fall 10 times during that month, they only fell down 3 times. So to me, that is benefit. A little bit is better than nothing. So we have to take that into consideration. And once again, that benefit from the levodopa might not be as robust as what we typically see in a patient with Parkinson's disease, but still, a little bit is better than nothing, okay? So a reasonable way to try the levodopa, and please don't do this at home. Just make sure that you follow this up with your doctor. But a reasonable way to try levodopa is start the carbidopa levodopa 25-100, half a tablet twice a day, and try this for a week to make sure that you tolerate. Sometimes people will have a little bit of squeeziness in their stomach, a little bit of discomfort, but then they will be able to tolerate. And then after that, increase to 1 tablet twice a day, then go to 1 tablet 3 times a day. And if you get to that point, don't give up. Just like Dr. McFarland was showing in a slide earlier, there are patients that we push them up to 10 pills of carbidopa levodopa, so 2 pills, 2.5 pills, up to 4 times a day. Because if the person is not developing any side effect from the medication, it is worth to push it that high, because sometimes we are going to find a patient. So if you take the medicine 1 tablet 3 times a day, you don't have any side effect, you didn't see much of a benefit, I wouldn't give up at that time. I'd actually will push it a little bit further. Observe always for worsening of the orthostatic hypotension, so the dizziness when the patient is standing up. And then the other thing that could happen is that there might be some drowsiness, so always pay attention to this and discuss with the doctor to make an adjustment to the medicine. I personally try to stay away from dopamine agonists because they are more likely to cause orthostatic hypotension. And not only that, it can cause confusion, it can cause hallucinations, it can cause cognitive decline. So you have to be very careful. It doesn't mean don't try it, it means be very careful as you go with it. But in any game, I will try levodopa first before trying a dopamine agonist, okay? So my recommendation is stay away from dopamine agonists, at least for initial treatment. Try to push the levodopa as far as you can. There's a medication called rasagiline. It was tested in people with multiple system atrophy. Unfortunately, no benefit was observed. And then there are other medicines that we use for the treatment of people with Parkinson's, such as entacapone, just to mention one of them. I personally don't see any benefit from the medication. If at all, it will worsen the dyskinesia, so I don't think that there is a role in the treatment of MSA. So let's talk about dyskinesias and what can we do when they happen. So it's not uncommon for me to have a patient coming to the clinic and they're saying, you know what, doctor, I think that the levodopa seems to be helping. However, I do feel that the dyskinesias are bothersome and I'm a little bit annoyed about them, okay? So when this is happening, there are 2 options. Many times the dyskinesias are in the face. It can happen in other part of the body, but many times it can happen in the face. So there are 2 things that we use. One of them is treatment with botulinum toxins. So the same thing that are used for the wrinkles, your neurologist might be able to adapt it to use it for the dyskinesias to try to minimize. It's not a cure, but it will try to mitigate that abnormal movement. The other medication that we can use will be a medication called amantadine. And some people try amantadine 100 milligrams 2 or 3 times a day. They develop side effects from the medication and they give it up. But what many people don't know is that there is an amantadine syrup, a liquid formulation of amantadine. So you actually can start with a lower dose of the medicine. Instead of taking 10 milliliters, just go ahead and take 5 and see how you do. And many patients will be able to find that they will have at least some marginal benefit from this, which is, again, better than not having any benefit at all. Remember that the main goal is to mitigate the symptoms, try to cause a little bit of a benefit to improve the quality of life of the patient. Sometimes, if this fails, you might attempt to lower the dosage of the levodopa, which is typically the cause, what is triggering the dyskinesias. But what happens is that if you cut back down on the levodopa, then those symptoms that might have been getting better, like the walking, the stiffness, the tremors, might get worse because you're lowering the dosage of the medication. And then the other thing is the dystonia. So dystonia is an involuntary contraction of the muscle. And typically, and very common, I have patients coming to my clinic because of dystonia in the neck. And a very common occurrence in patients, people with MSA, is that they develop a posture where the neck is just hanging down, sometimes you will find that your family member have this. And I want you to be very careful, and I want to make sure, and this is the take-home message, make sure you see somebody with experience in this kind of conditions, okay? I see a lot of people with dystonias. However, there is a condition where patients might develop what we call a myopathy, which is a weakness of the muscles that keep the head up, all right? So in somebody with dystonia, which is the enterocollis, for true enterocolic dystonia, they will feel that the muscles in the neck are pulling the head down. In a patient with a myopathy, the muscles in the back of the head cannot keep the head up. So what is going to happen is that if you treat a patient with Botox, botulinum toxin, thinking that they have enterocolic dystonia, when in fact they have a myopathy of the cervical paraspinals, you may make things a little bit worse, and you're exposing the patient to have some trouble swallowing. So this is very critical, and I see this all the time coming to the clinic, and sometimes patients are frustrated because they think that I'm going to give them that Botox, that they were told that it was a dystonia, but the truth is we have to make the proper diagnosis, and you know what? Sometimes there might be some other things that we can target this, okay? Deep brain stimulation, there actually has been studies on deep brain stimulation, and unfortunately we have not seen much of a benefit back in the day. And back in the day, we're talking 2003, 2004, I was a fellow at that time. We were so excited about DBS, and we did a few patients with multiple system atrophy trying to see if we can capture some benefit. And those that have a lot of tremors will get better, but other than that, we just didn't see much benefit. I don't think that it was worth to go ahead and do this procedures. IVIG, which is an intravenous immunoglobulin, has been tried properly, and we haven't seen any benefit. And then there are some other medications that have been tried. Rifampicin, there has been some stem cell treatments back in the day. We didn't find any benefit. The ataxia, which is the incoordination, we haven't seen much of a benefit. I still give the fight. There's a medication used for anxiety called Buspar that I try for anxiety sometimes, and there's a medication called Ambien, the sleeping pill, that I tried every now and then for ataxia. Once again, I might have 2 patients out of 10 coming back. At least for those 2 patients, we're able to improve their quality of life. There has been some other research, and probably later we're going to be talking a little bit more about this, but unfortunately, we still do not have a treatment to slow down the progression of the disease. And there's a research project now on verdiperstat, which is ongoing, again, trying to see if we can slow down the progression of this condition. So, just to close it up, I only have 10 minutes for this. So, as doctors, and this is my message to you, okay? As a doctor, I cannot predict who is the one patient that is going to improve with the levodopa, okay? The only way to find out whether you are that patient is to try the medication. Start with a low dose, build it up over time, just to make sure that you will be able to tolerate the medication. You have to be open-minded, and even though you might not see that benefit that other people see in people with Parkinson's, but I think that a 20-30% improvement is better than a 0% improvement, right? If we talk about dollars, 20% of $1 million is better than 0% of $1 million, right? So this is the way that we have to see it, and we have to give that fight, okay? Sometimes, patients don't find any benefit from the medicine, and it is that they try to low dose. Once again, just try to push it, and then I have a lot of patients that come to the clinic that they do not want to try the medication because a friend of them had a side effect or they had a bad experience. And guess what? No two people are alike, right? One patient might have a problem, your friend might have had a problem, but then you might try it and you might find some benefit. So I think that it's worth to try this medication. And that's all I have for you today. That's in a summary what we have available right now for the treatment of motor symptoms in people with MSA. The most critical part is you have to make sure that you see somebody that has some experience that can explain very well what is it that we're looking for from these medicines. What will be the correct expectations, and make sure that you're trying the correct dose of the medication. So a little bit later, we'll have some time for questions. I really appreciate your attention. And I have to say to the organizers, you guys are doing a fantastic job. I am very impressed. Thank you for the invitation. All right, Tom.
Thanks.
You're up.
I love your analogies.
Oh, thank you.
For 1 second. Just a quick reminder to everyone here in the audience, would you mind putting your phone ringers on mute, just as a courtesy to the speakers and the rest of the audience. And for those of you watching the live stream, you are able to ask questions that we will filter and then ask to the panels. You can either comment on our YouTube page or comment on our Facebook page or tweet to us at MSA Coalition. We're monitoring all of those. Thank you.
Thanks, Neil. Do you know where it is? Having trouble finding it. It's probably right in front of me, but I don't see it.
Should be this one. That's motor.
Okay. Great. Thank you. Sorry.
No, you're fine.
Yeah. Okay, thanks. Well, it's a pleasure to be here. It's always an honor to be invited to these conferences, and thanks for listening to. I love Ramon's analogies. I thought they're just great. So I thought I would start out with a kind of a fun slide, and why do giraffes not faint? Before I even get to that, I'd just like to explain what the autonomic nervous system is and does by an example. So if you're in Los Angeles and you're heading to the beach, and as typically happens, you're in your convertible Porsche, and you suddenly run into a traffic jam, and it's going to be 3 hours before you get to the beach. Probably not much is going to happen. But if you're in your little Ford Escort that's got one tire that's not working very well, and you got your first job interview in 2 years, and you run into a traffic jam, so you know you're going to be late to the interview, what's going to happen? Well, your blood pressure is going to probably go up, your heart rate's going to go up, and if you're really scared, you might even have a bowel accident of some kind, or a urinary accident. And that kind of summarizes, in a nutshell, what the autonomic nervous system does. It's managing your body to coordinate it with what's going on in your mind. And if you're really good with yoga or can take some deep breaths in, you can probably control all of that. So it's really not a system that just works off by itself. It's a system that's coordinated with your brain and reflects various stages of readiness. And that's really one of the major things that goes wrong in multiple system atrophy. You're no longer able to coordinate what your brain says your body needs to do with what the body actually does, because the coordinating centers in the brain are no longer working. I'm going to focus on just one thing, which is blood pressure, why your blood pressure doesn't work or blood pressure control doesn't work. And I'm starting with this slide, which is giraffe versus man. And giraffes don't faint, even though they're much taller than we are and have much more cardiovascular demand. They don't faint. And the big difference between them and us is the amount of blood that's beneath the heart when they're standing. So when they're standing, I taught a class, some undergraduates at Case, and we went to the zoo and we saw giraffes, and a veterinary giraffe expert told us they're basically cows on stilts. That's what they are. So I thought that I kept that in my mind, a cow on stilts. The point is they have essentially no blood in their feet, and NASA actually used the way the giraffe manages its leg to build the space suits, because it constricts so well. If you compare that to human being, you'll see that the amount of blood in that picture below the heart is a huge amount of blood, and it's actually a miraculous feat that human beings can normally stand up. It's a little bit like the bumblebee being able to fly and get off the ground. So now, how is this all done? I'm not going to go into detail here. I'm just mentioning the word baroreflex, so you've heard about it. The baroreflex is basically like the thermostat in your house for heat. This is the barostat, the pressure stat in your body for blood pressure. It's got two parts. It's got one that makes blood pressure come back up if your blood pressure drops, and one that makes your blood pressure come back down if your blood pressure goes too high. And in multiple system atrophy, this thing basically, the centers that coordinate this stop working. So it senses changes in blood pressure, and it adjusts blood pressure. And really the only thing I want you to remember from this slide is that the main thing that needs to happen if your blood pressure drops is your vessels need to tighten up. We don't have the giraffe's suit system, so we gotta tighten those blood vessels. Anything else is really not gonna do too much. But we can do that externally by giving you some pressure hose. And that's the point of pressure hose, is to make you a bit more like a giraffe, so if your vessels don't constrict, we can still get blood back up to the brain. Now, it's important to realize that in MSA, not only do we fail to raise blood pressure when you stand up, we also fail to lower blood pressure when you lie flat. And I'll show you that in just a second. Now, we are able to test these various features in what's called an autonomic laboratory. How many here have had autonomic testing, where you've gone to a lab and had, so I see a fair show of hands, probably at least more than a dozen people. And I'm not going to tell you all about autonomic testing. I'm just going to focus on one thing, which is the cardiovascular system. And the tilt table test basically tells us if you have orthostatic hypotension or not. It means, does your blood pressure drop when you stand up? And that's shown in this particular slide, where you see that here's the person tilted up here. This is the tilt angle. The person is tilted here, and you see the blood pressure drop, drop, drop. This particular person is able to compensate by increasing the heart rate, but you can see that it doesn't actually do a lot. The heart rate increase helps a little bit, but once you're not able to maintain blood pressure, that's a very difficult problem to resolve. Now, orthostatic hypotension can be neurogenic or non-neurogenic, meaning it can be a neurological problem or not a neurological problem. If you have MSA, it's going to be a neurological problem. But we don't know that when we first see you come into the office the first time. So the autonomic testing also includes what's called a Valsalva maneuver, where you kind of put pressure in a tube for 15 seconds. And during that time, we measure, are your blood vessels able to compensate for this? Are you able to maintain blood pressure during this? And I'm going to use the arrow for those who are watching on video. So you see here, the person puts pressure into this tube right here. And then right about here, blood pressure begins to drop a little bit. And you can see this person is well able to compensate because blood pressure then after, this is a 15-second period. And during this 15-second period, about 6 or 7 seconds, the blood pressure is dropping, and then the person compensates very well and comes back up. In contrast, this is a person who's perhaps has multiple system atrophy. You can see that they have that initial drop, and then what happens? It keeps dropping. And that's pretty much how we define neurogenic orthostatic hypotension, is through the Valsalva maneuver. We can tell that the problem is the nerves are not telling the blood vessels to constrict, probably because they're not getting the message. Now, this slide shows the point I was making before. Trimethoprim is a very, very old drug, and it blocks the ability of norepinephrine, which comes out of the sympathetic side, the fight or flight side. It blocks the ability for that to happen. And the point of this slide is to show that when patients with multiple system atrophy have high pressure, how many here have supine hypertension, have dealt with that? So supine hypertension is not that common, but when you have it, it's not just that you took too much salt or did too much during the day. It's actually that your baroreflex is providing a signal, is saying constrict the blood vessels at a time when it should not be. And that's what this slide shows. If you block that system, then patients with multiple system atrophy do not have that high blood pressure, that supine hypertension. So it's a problem that comes from the brain. Okay, now I just want to say a few words about how you manage blood pressure. And most physicians are very familiar with the drugs, or somewhat familiar with the drugs. So I'm going to emphasize here things you can do, things that not relate to drugs, to help manage your blood pressure. Now remember, you've got two problems most of the time. You've got a problem that your blood pressure is too low when you stand up, and you've also got an issue that your blood pressure may be too high when you lie flat. So you have to manage both of these, and timing is of the essence. So one of the big things, when people come to my clinic, one of the big things I see is that physicians have put them on all the right drugs. They're on, perhaps on mitogen or droxidopa or any of these. But the issue is they haven't told the patients to take enough salt. Think of it this way. That big picture we saw at the beginning with the giraffe and the man, that's your well. And if that well is not filled with fluid, it's very hard to pump it. So the drugs mostly pump, except maybe for high doses of Floridef. Most of the drugs just pump the well system. If your well is empty, the pumping is not going to do a very good job. How do you fill it? Mostly with salt and fluid. So most of the patients I see who come to me are not taking enough salt so that the drugs can really be effective. Now, this picture is really to remind me to talk to you about microgravity. So every time you lie flat for more than an hour, you experience what's called microgravity, which means that your system is not being triggered to maintain blood pressure. When you do that for 8 hours overnight, you experience a lot of microgravity. That's the reason we tell people to elevate the head of their beds. Now, when the astronauts come back from a space flight, and actually this was not taken, this was taken before they went, but when they come back from space flights, typically the pictures are taken in the space suits. And you figure, well, that's for good advertising. No, it's not for good advertising. If they come back from space flight and you take them out of their suits immediately, they're going to faint. Because gravity is required for the signal to be transmitted. If you not exposed to gravity for a couple of days, as maybe many days, as the astronauts are, then your system stops functioning and you no longer have the baroreflex. So think of MSA as being also not responsive to the gravitational signal. Now, how much salt do you actually need to fill the well? Probably about 8 to 15 grams per day. So somewhere around 2 to 4. Normal American diet's probably about 3 grams a day. You need way more than that. You need at least twice that. It's only limited by if your blood pressure starts going up too high. That's what limits it. High pressure hose are another way. We talked about that a little bit earlier. Makes you look a little bit like a giraffe and makes the leg do the work for you. And elevating the head of the bed is how you eliminate microgravity. So you have, and then you eliminate much less fluid or body volume during the night, and then you have less supine hypertension. I had a call from a resident one day who said, your patient with multiple system atrophy, the blood pressure is 250 over 150, what do I do? I said, just sit him up. That's all you have to do. Then the blood pressure will be 120 over 80. Salt has two actions. People may not be aware of this. One action is to have an acute effect, which raises volume, and the other action is to have a chronic effect that constricts the blood vessels. So start with 2 grams twice a day and go up. This shows the effect of, do I need to stop? How about 2 more minutes? Just shut me up when I'm done. So this shows the effect of various non-pharmacologic measures on plasma volume. And these are fainters, so it's the time they faint. And you can see elevating the head of the bed, that's symbolized in the black symbols, does a very good job of increasing total volume. Salt, the square dots, does a pretty good job. And exercise is something else I recommend, does a very good job as well. Now, a few other non-pharmacologic tricks up our sleeve. So this is to help the vessels constrict. The others were to expand the well. If you drink water, that's been studied very carefully. If you drink water, a big glass of water in the morning will elevate your blood pressure about 30 to 40 millimeters of mercury in about 10 minutes and will last about an hour. So recommend everybody do that when they first get up in the morning. Frequent small meals, because insulin is a vasodilator. The physical counter maneuvers I've got a picture of in a second. And then physical exercise improves how the baroreflex functions, presumably by exaggerating the role of gravity when you're exercising. And then self-tilt exercises are very, very important because they help the system constrict. So let me show you these. So this is a picture that shows the effect of drinking water. Does that show up? Oh, it doesn't show up on the slide. Okay, so I guess I have to use this. So increasing water drinking, you see the blood pressure come up after drinking water. These are the counter maneuvers. So if you feel like you're going to faint, you can do any of these. You can squat, you can tighten your legs, and that'll increase the blood pressure acutely. And this is the effect of tilt training. You basically stand up against the wall, and you stand there for 5 minutes or so. And this shows you in a group who faint how well they do. So initially they're fainting at about 10 minutes. And after 2 weeks of tilt training, they're able to stand 30 minutes. So that's very important. Now, I'm just going to cover 4 drugs rapidly. Drug number 1 is fludrocortisone. Most of you have probably either on it or have tried it. People are not aware that it has 2 effects. In low dose, it makes norepinephrine work better on your blood vessels. So it produces a better response. So I sometimes use it in a very low dose, which is a half a pill 3 times a week, if that's all I want. If I want to fill the well better, then I use the normal dose, which gives me an increase in blood pressure. The next drug is a drug called pyridostigmine. It's a little bit like power steering. So what power steering does is you turn to the right and it helps you turn more to the right. You turn to the left, it does that. Pyridostigmine, when you activate the autonomic nervous system, it just activates it a little bit more. And the nice thing about it is it does not have much of an effect on the lying flat pressure. It only increases the blood pressure when you're standing up. Midodrine, probably most of you are familiar with. It does the job norepinephrine does by constricting the blood vessels directly. It lasts about 4 hours. You should be careful not to take it if you know you're about to lie flat. And then the last one I'm going to cover is it's quite old. It's 30 years old, but it's only been on our market for a few years. And droxidopa works like L-dopa. For dopamine, droxidopa works for norepinephrine. It allows your system to release more norepinephrine. So I had a few slides on supine hypertension, but I think I'm going to skip those in the interest of time. And I want to thank you very much for listening, and thank you for the MSA Coalition for inviting me. Thank you.
Okay, it is a real privilege to be speaking in this meeting, and I share with you guys the frustrations, especially related to the GI tract, when you feel all these symptoms and treatments may not be as effective. So my objectives today will be to discuss the general manifestations of GI-related issues in patients with multiple system atrophy, and I'm going to start talking from top to bottom. Then I just want you to be aware of something called the brain-gut interactions, which are very important in the development and in the cause of these symptoms that you are feeling. And then perhaps the most important point that I want to make today is to make you understand that early recognition of the problems with the GI tract and aggressive treatment of these can improve your quality of life. And then just out of curiosity, raise your hands, the ones who have any swallowing or constipation related issues. So quite a few patients. So the brain-gut interaction is very critical. I guess if I step out, you may not hear well, but so you have what we call the little brain, which is what makes me a neurogastroenterologist, and it's called the enteric nervous system. The enteric nervous system is a group of neurons that independently function to regulate interactions between the germs that you have in your gut, the hormones that go through, the food that get through, all of the immune antigens that you swallow and you eat and you breathe, and it's like a traffic controller. And believe it or not, is so powerful that on its own can control the motility of the GI tract, meaning how you push food through. Then also controls the juices, the hormones, and the secretions that your GI tract makes in order to help you digest, and also controls the blood pressure or the circulation to the gut, because in order to digest, you need to accommodate, and that's a very important part of the autonomic nervous system that we have discussed already. Then the good thing is that the enteric nervous system, although it's autonomous, it can be affected by bidirectional communication between the brain, which is kind of the main controller, then your spinal cord, which is like a stop in the signals. Then you get the vagus nerve, which is the main deputy that will control the signals and make sure that the GI tract functions adequately. And then the gut itself, that on its own, is very important to regulate things. For example, when you eat too quickly or too much, you get distension by the food, distending in the stomach. Then the GI tract will send a signal to your brain, telling your brain, please stop eating. So this axis or this interaction is very important for you to understand why you're having all those symptoms. Then, specifically related to multiple system atrophy, there are several areas based on, as Dr. McFarland was saying, neuropathology, where it's being demonstrated that there is degeneration of neurons or part of the neurologic system in these specific areas. And one is the cerebellum. The cerebellum is very important to control swallowing. Basal ganglia, same thing. That's why, it's frequently present in patients with this type of conditions. Then you have the vagal nerve that, as we mentioned, it basically controls the input to the intestinal tract in motility, secretion, and many other things like sensation. Then you have the spinal areas that are very important because the vagal control basically helps you to contract and get accommodated to digest food. Then the other part of the control needs a balance, so the spinal areas can control and counteract that, which is very important as well. Then you have the sacral lower part of the spine that controls defecation. That is a very important part of physiology, and that's one of the main issues that patients with constipation will have. And then, the anal sphincter is also very important to be controlled, and we have several abnormalities when you do biopsies and see the neurons that control these areas. So the good news is that based on the studies, there is no problem, or there is no alteration of the little brain neurons. Therefore, there is hope for eventually get some treatments that may improve the symptoms. Then from top to bottom, there is a lot of symptoms, and you guys, have experienced some of those, and you have known about those from these talks as well, including drooling, trouble swallowing, problems with the food pipe to push food through, a sluggish stomach, a sluggish colon, rotation or flipping of the colon on its own from constipation, and trouble to get the bowel movements out. And then all those factors will induce a significant problem with quality of life. Most of my patients that have neurologic conditions tell me that perhaps constipation and trouble swallowing is at least equal or perhaps worse in terms of quality of life. So this is a very important part. Then, for various reasons, including trouble with secretions, trouble with protection, trouble with reflexes, there is a risk for sudden death from suffocation on your own secretions. Then complications with medication intake, because if your stomach and your colon are not moving, your medications are not going to be moved either. And then obviously when you are not able to eat and enjoy food, then you may have some degree of malnutrition. So starting from the top, salivary problems with drooling are not uncommon, and the good news is that the issue is not that your mouth or your salivary glands make too much saliva. The problem is that it's difficult to get rid of the saliva or to swallow the saliva. Then the only way that the saliva that is pulling can come out is basically by just coming out of your mouth. The treatment for this is basically try to avoid medications that can make this worse, and several of the medications that you guys take can make this worse. Then behavioral modifications that are very simple, just getting set up times to swallow, because you may forget to do that, then you're going to accumulate more saliva, and then small or simple things like that can help significantly. Then there are other medications that dry up your salivary glands that don't have any significant central related issues, like ipratropium and glycopyrrolate. And then on severe cases, there is some case descriptions that Botox injection, this time to the salivary glands, dry up those glands and make you less likely to have the drooling. And then in very extreme cases, they have even done radiation therapy. Then swallowing disorders, in gastroenterology, we see swallowing in two main parts, the mouth and throat, and then the food pipe itself. And then patients with MSA have problems in both phases, perhaps more likely related to problems with the oral and pharyngeal phase, meaning what is in your mouth. And for various reasons, the mastication, chewing is difficult. The tongue moves not organized, and believe it or not, tongue movement is an important part of the propulsion of food from your mouth into your pharynx, into your throat. Then the sphincter, the valve that you have on top of the food pipe, needs to open up for food to get through. That may be altered, and then all those can give you significant issues with swallowing. Then the food pipe itself is very well described, that food can get there and stay there for longer than expected. Then the contractions of the food pipe may be weak. Then on time, when you have so much food getting retained, your food pipe is going to become dilated and baggy and not, able to squeeze as strong. And you can even have very abnormal motility that push things back. This is a very significant problem, trouble with swallowing. In about 75% of patients is a common complaint. And is even more problematic with patients that have the Parkinsonian part or manifestation of this condition. And this is important because trouble swallowing can get things from your mouth and when you eat there, and that can go into your lungs, and that can do to aspiration pneumonia, which is one of the most feared complications from this type of issues. Then, as we were discussing, this is a progressive disease, and for whatever reason, the patients that have the Parkinsonian features tend to present these problems earlier, and the deterioration seems to be faster. And then studies also have shown that from all of those phases of swallowing, the most important part that is altered is from the mouth and the throat into the food pipe. So that's very important. I just wanted to point this from a study that basically show that the food pipe is dilated. The arrows are showing that the food pipe is featuring in like a darker, like gray. So that's food that is staying in your food pipe. And they took 16 patients from which all of them have food retained in the esophagus and the food pipe. And from those, 7 were labeled as severe, meaning that the food was going all the way up, almost to the neck, as you can see here. These are the clavicles, and this is your neck. So the food column was all the way up. What you can do to improve this, you have to avoid dried solid food, chew very well, watch things down with liquids, and you can try to modify consistencies. Liquid thickeners can be very helpful for this. Then when it becomes more severe, there are speech and swallow based therapies that have seen to help, the EMST, the expiratory emotional straining, the video-assisted swallowing therapy. Not all of the centers have this availability. Then there are some case reports that Botox to the food pipe, to the bottom of the food pipe, can let the food go into the stomach. And then dopaminergic drugs, driven stimulation, have been treated. And some patients may experience some improvement, some patients may not. Then, we have discussed already that you have to have an open mind, because what works for some patients may not work for others. Then there is always a chance to get tooth fittings. One thing that sometimes is a misunderstanding is that the feeding tubes will not prevent aspiration, and they should be only used as a means of nutritional support. The reason for that is because the mortality rates from PEG tubes are very significant, not because of the tube itself, it's because normally this tube is placed at the very end of the spectrum of the disease when all of the issues are more prevalent and more prominent. Then I'm just trying to go through all of the organs, so forgive me if I'm going too fast. But the other problem that is very obvious is that the stomach is not emptying, and then in this particular side, this is a normal patient that empties much of the stomach, and then this is a patient with Parkinson's, patients with MS that basically show that the emptying is dramatically more sluggish. And this is almost universally present in patients with MSA. What you can do, the main treatment for this is what we call gastroparesis diet, that in a nutshell is low fat, low fiber, because fiber and fat tend longer to get out of the stomach. So that's the main approach for this. Then dopaminergic receptor blockers, we have discussed that dopamine is a major player, and whatever you do to the dopamine can derange other axes. And the problem with some of these medications is that they may cross to the brain, and they can worsen tremor and movement disorders. One medication that has been used with some success is domperidone, that is relatively safe and theoretically can kind of counteract a little bit the autonomic orthostatic hypotension that the disease itself and the medications that you may be taking can give you. So this is kind of a double benefit from this medication. Then we also use some antibiotics that, in addition to that, at low dose may promote motility. There are a couple of antibiotics like that, like azithromycin and erythromycin. Then there are other medications that can help with gastric emptying. One of these is one that has been recently approved, which is also helpful because this medication, prucalopride, can also help with constipation. So with one medication, we can improve other gastrointestinal segments. And then there are other interventions that are a little bit more aggressive that have been try in small settings and small groups, and they may be beneficial, including Botox to the stomach, deep brain stimulation, cutting the muscle at the bottom part of the food pipe or the stomach, and this has been described mostly for patients with Parkinson's disease, but there are some case series that have treated this as well. Then constipation, perhaps is the most significant autonomic complaint. Is present even before the motor on the tremor is fully expressed, and that can be present for years, decades, even before that happens. And it's very important to be on top of this because it's kind of a marker of, the disease in the future. There are several complications that if you don't take this seriously can happen, like colonic bolus, which is twisting of the colon on its own from having too much stool, dilated your colon, making it baggy, so it's more likely to flip on its own. And then again, this is a significant limitation for the quality of life for patients and caregivers, and is equally frustrating to us as physicians. There's, again, several complications that can be very serious, including subduction, and sometimes you can get food impactions, fecal impactions, meaning stool kind of trap at the bottom that can be so bad that can limit the blood supply to the gut, and that can induce perforation and bleeding and colitis as well. Then, as we have discussed, because of the autonomic control, the brain control, the brain-gut interaction, there are many causes for that. The colon is maybe sluggish. The rectum may have weak strength to push stool out. The abdominal muscles, because those are also impaired by this condition, can be weak, so it's more difficult to strain and push from the abdomen, which is a very important part. And the sphincter itself, that can be denervated. The anal sphincter can be very weak. So basically, what you do is to try basic things like diet changes. Then, if that doesn't work, you can have stool bulkers, that is the Metamucil. Then that may or may not work. Then you can have Miralax, which is going to be a laxative, making your stool a little bit less firm. Then you can try stimulant laxatives like bisacodyl that can give you a little bit of cramping. By the time that you are already fail all of this, then there's a good time to think about medications like prucalopride that will also help with gastroparesis. So it's good news. Then the Linzess medication has been recently in the market. That can help some patients as well. And then you can always reassess or change therapies. And the hope is that you will improve the transit of stool and the constipation. Then for patients that are responsive, you can do biofeedback. That is basically a therapist that is going to make you aware when you're going to have a bowel movement and how to improve the contractions on the abdomen and the relaxation for the anal sphincter. At worst case, you can do enemas, which are very, if I done well, they will not hurt and they will not damage further your colon. Then you can use things like the sacral nerve stimulation that seem to relax the muscle and help a little bit. And the same thing that you can treat with fecal incontinence, because sometimes it's overflow from so much stool that basically stool will leak out. So very important to treat the constipation so we don't get all of these worse outcomes. Few slides about what happens. So this side here is a food pipe. It's called megaesophagus because the bottom was not opening well, and it became so big that it was almost occupying the entire chest. Then this is a colon that has flipped on its own and is almost occupying also the entire abdomen as well. This is a surgical emergency. And then this is a megarectum, meaning the colon is so much full of stool that has this modded pattern that definitely, by this stage, you will not be helped by laxatives or fiber. So the goal is to make sure that you treat this early so you don't get to these extreme conditions. Then I will save questions for the end.
Well, truly honored to be here, and while I'm pulling up my slides, I just wanted to thank Dr. McFarland and Cindy Romer and the MSA Coalition Board for inviting me to speak to you. So thank you, and it's a great opportunity to speak also to meet some of the patients here, and I think it's really a different sort of venue for me to speak at. So if I can find my slide here. That side. Slaves. Should be the ladder right there. Oh, okay. Looks different. All right. Well, so I'm going to talk. I'm a urologist and not a neurologist, and I'm going to speak a little bit about the MSA and the bladder. So no disclosures here. I'm going to skip through this part here. As you know, many patients with MSA have significant lower urinary tract symptoms. 96%, my practice 100%. Everyone I see has got a problem. That's why they're there. And the variety of problems can really range from having difficulty with voiding to urinary frequency and urgency to complete urinary retention. The really most important part, I think, of patients with MSA coming in to be evaluated in any neurologic disease is really the evaluation, understanding what the real problem is, and trying to pinpoint what the exact bladder issue is going to be. And of course, you do this with a good history and physical examination. We'll often have patients do a voiding diary. I typically will do an intake voiding diary for a couple of days where people keep track of what they drink and what they put out, so I can see how often they're voiding, what volumes they're voiding with, both day and night, so we get some objective evidence of kind of what's happening at that time. Because unfortunately, oftentimes we're kind of poor historians, but it gives us also a way to measure how things change over time. We'd like to check a post-void residual. Patients with MSA as compared to patients with Parkinson's disease typically have more issues with bladder emptying problems. So post-void residual is after you've voided in the restroom, you check a residual to see what's left over, and then that's how much we get a sense of how well your bladder is actually emptying its contents. And so that's helpful for us. And for those patients where we, or at least certainly I don't get a good sense of what's going on, we can do a more sophisticated testing, something called urodynamic testing. It's a little bit invasive, so we don't kind of jump to this right away. This is basically a study where catheters are placed in different orifices, so not the most fun test for most people. And we try to assess what's happening to the bladder while it's filling and while it's emptying to get a sense of actually what's going on so we can sort of pinpoint and direct our treatments. Our goals of treatment are really going to be to relieve symptoms, so we're trying to improve or decrease the symptoms that are bothersome to the patients, in doing so hopefully improving the patient's quality of life. And also for me as a urologist, what I worry about, the whole urinary system is sort of interconnected. So what you really want to do too is protect the upper urinary tract, because you have to have the kidneys to live. Obviously the bladder issues are going to be bothersome to you day to day, but how they also affect the kidneys can be problematic, and we want to make sure we protect the bladder. So this is just sort of an algorithm and how we typically will evaluate patients. Here at the top part, you're really trying to rule out other diseases. When patients come in from with urinary symptoms, what you're really trying to do is, obviously if they have a neurologic disease, it may be due to the neurologic disease, it may be due to something else, and you don't want to jump to the conclusion that it's just the neurologic disease. So you want to make sure there's no other issues kind of going on as you're evaluating them. As you kind of, once again, rule out other abnormalities, once again, as I talked about during the evaluation, you may end up needing to do a post-void residual, checking how they're emptying, as well as this urodynamic testing to pinpoint a little better about how they are empty, what their bladder is doing as they're being filled, and what it's doing when it's emptying. And you kind of end up with a couple of different potential scenarios. One of the scenarios is everything's seemingly okay, symptoms are not particularly bothersome. You can kind of watch and wait and kind of observe that patient over time. If their symptoms aren't overly bothersome, they're emptying their bladder well, we can watch that. Sometimes if they're just minimally bothersome, you can do things like pelvic floor therapy or behavioral therapies like tying, voiding, etc. So non-invasive therapies to start off with. In those patients, and we see that they're emptying their bladder well, so they're not retaining the urine, but they have symptoms of what they consider overactive bladder, which are symptoms of urinary frequency and urgency and urgent continence. These are patients who you would typically treat pharmacologically with anticholinergics, antimuscarinics. That's kind of first-line therapy along with behavioral therapies. Beyond that, there's other treatments such as using Botox, which we've seen in other organ systems here, but using it in the bladder where we can inject it directly into the bladder wall. There's different nerve stimulators that we use, sacral nerve stimulators as well as posterior tibial nerve stimulators, which may be helpful. And so those would be sort of the, we consider third-line therapies in urology for those symptoms. It gets trickier when patients have these same symptoms of urgency frequency. So we think of their bladder as being somewhat spastic, perhaps, and their bladder is not emptying well, so they're holding large residuals. And these patients, you may need to work. We don't have great medications to really get the bladder to squeeze better to empty. So oftentimes, most of our work is done at the urinary outlet, where mostly in men, they may be obstructed with a prostate that's enlarged also. So there's medications that we can use, alpha adrenergic receptor blockers, to basically relax the bladder neck, or sometimes even different things like a prostatectomy in some patients if their bladder is functioning normally. Because oftentimes the medications like the anticholinergics can put patients who already have a poorly functioning bladder into retention, or they may be retaining more. Thirdly, there's also patients where they just have large post-void residuals with, in other words, they're not emptying their bladder very well, they don't have any urinary urgency symptoms or bladder overactivity, and then we just have to figure a way of trying to empty their bladders. The hard part is when the simple therapies are done. There are a number of other therapies which can be considered with intermittent catheterization. That means catheterizing yourself once in a while to basically empty your bladder, indwelling catheters, and there are more significant reconstructive procedures after that, and we try to avoid those if we can, but they may be necessary in trying to maintain a quality of life. So my talk's a little short here to make up some time. We can take some questions once again at the panel. It's a good time if you have any specific questions about this. Overall, my conclusions are that, obviously patients with MSA have a lot of bothersome lower urinary tract symptoms. The important part is characterizing these symptoms in my mind, so we can try to pinpoint what kind of therapy is best. And of course, there's a number of different treatment options now. There's more than there have ever been. They're not all perfect, but I think once again, the goal, and for most people, is trying to improve your quality of life. Okay, thank you very much.
How's everybody doing? I do realize we're running over a bit. There's so much to cover here today, but we want to give you a good overview. If we're not doing well, let me know. Is everyone doing okay? I'm going to try to go over sleep briefly here. I'd hate to give anything short shrift, but we will be here as a panel after the break, and you guys can ask as many questions as you like in an hour. Let me just go over, and I want to point out just a few things about sleep. Again, I want to sort of acknowledge Dr. Holly Skinner from Advent Health, who helped put together this talk for us today. Okay, here. So sleep is a big issue. Obviously, we all need a good night's sleep, and sleep gets disrupted in multiple system atrophy for many, many different reasons. Common things happen in other Parkinson's disorders as well. But these are some of the symptoms, basically, that we see in MSA. Insomnia, daytime sleepiness, restless legs, we call REM sleep, or sort of dream enactment behavior, and then disordered. I'm just going to go over them very briefly here if I can. Okay. So insomnia, so problems with sleep are very, very common in patients. On the right-hand side, I'm just going to show you, these are polysomnographs, okay? This is what we do. We bring patients in and do formal sleep testing. We put wires on the head and we look at your sleep cycle. And essentially the way we look at sleep cycle is there are stages of sleep. The first stage of sleep really we enter is what's called REM sleep. REM is what's called rapid eye movement, okay? You're supposed to be dreaming. Your eyes move when you dream, and your body's supposed to be atonic or not moving, okay? And you can see here that you go through different stages of sleep, stage 1, 2, 3, 3, 4 are really deep sleep. That's what you want. And people kind of cycle through, but this is a normal person where they have nice, long stage 3, 4 sleep here. This is insomnia with a lot of different arousals here. There are lots of different reasons people have insomnia, and these are some of the different kind of issues, okay? With multiple system atrophy, the discomfort can be there. There can be agitation. There can be the urinary issues, getting up so many times to go pee, and other issues that can disturb sleep here, okay? So these are just general strategies. I'll let you have these slides, essentially. But basically, number one really is just practicing good sleep hygiene, okay? Getting ready for bed, okay? Trying not to eat late at night, trying not to drink after dinner if you possibly can. Excessive daytime napping or sleeping can sort of interrupt your sleep cycle, okay? Switching day versus night also, okay? And you trying not to get out of bed if able, is one of those other things you can do, avoiding prolonged time as well here, and then considering sort of referrals if you're having a lot of disturbed behavioral problems for sleep here, listed on the bottom. So MSA, there are a number of different strategies that we can do for sleep here, okay? If you're having trouble with sleep, there's a natural drug called melatonin. Melatonin's actually a natural chemical your brain makes to regulate your sleep cycle day and night. This is a herbal supplement that you can buy over the counter. I think, how many people have actually tried this? Probably quite a few. Okay. It's very well tolerated. Again, your brain makes it. It's a safe drug to try, actually. The key really is that you need to take it about an hour or two before you want to fall asleep, okay? They do make a long-acting melatonin that you can buy over the counter, an extended release melatonin now that might keep you asleep a little bit longer. But generally, this helps regulate your sleep cycle. We can do things like treat depression and anxiety. A lot of people lay there in bed and ruminate, okay, because they have anxiety or mood issues. That needs to be treated if it is present. There are other things that are listed in here I can go over. I'm going to go over sort of the obstructive sleep issues. If you do have what's called COPD or obstructive sleep issues, obstructive sleep apnea, then you need to be treated with a CPAP, okay, often. And then treating those urinary issues listed here as well. Okay, antispasmodic agents can be used. One that we probably didn't have time to talk about is this drug called desmopressin. So this regulates your urination, so that can sometimes help with frequent urination at night, in particular if given at bedtime for some patients. So, daytime sleepiness, common complaint among patients a lot of times, okay? So, if it's really bad, this can lead to sort of falling asleep. If it's happening during meals, this is a big problem as you're starting to eat and get these sudden sleep attacks. There are a lot of things that contribute to this, so disordered sleep, sleep deprivation because you're not getting sleep at night. There are problems with the sleep-wake cycle, and then medications can affect your sleep cycle as well, okay? Daytime sleepiness, okay, things you can do. As I mentioned, drugs are a big thing. Look for the drugs, okay? Have your doctor review those medications to see if anything's affecting that. Get a sleep study if you don't know exactly why you're not sleeping and you're daytime sleeping in. People have tried stimulants. There are a number of them that are out there. A lot of them are controlled substances. They don't really work very well, and they haven't really been validated in MSA. And that's not to say we can't try them, but just understand that they may have limited benefit in this patient population, okay? So let's talk about what are called polysomnia. So these are sleep disruptions, okay? Restless legs is one of the most common forms of this activity. So this is sort of a symptom that a lot of patients come to. This is sort of the symptom that you get usually later in the day where you feel this sort of creepy, crawly sensation in your leg and this urge to have to move them, okay? This usually occurs when you're at rest or when you're trying to go to sleep, and it's very disruptive, okay? Typically, patients want to get up and they will have to walk around. So this can happen multiple times in the instance type of multiple system rather than the cerebellar type, okay? There are a few things to look for. There are what we call primary restless legs and secondary. Secondary due to causes such as neuropathy and then low iron. So iron deficiency can be a treatment for your restless leg symptoms, okay? There are medications that can actually cause restless legs, so stopping those medications can be helpful. There are lots of things out there these days that can treat restless legs. Probably people out here in the audience may have tried things like dopamine agonist type drugs. Those are very commonly, and they're even advertised on TV to treat this. Other medications like gabapentin can be really helpful. In some cases, we need to use stronger medications and even pain medications to treat this. Watch out for the medications. There are other alternative therapies listed down below, like compression devices and things to help with patients. Special mention needs to be given for this REM sleep behavior disorder. This can be very disruptive. REM sleep behavior disorder has been recognized and increasingly recognized as a risk factor for Parkinson's as well as dementia. Okay, so, and it's also a disorder that can really interrupt sleep. Okay, when you're dreaming, your eyes should be moving, your body should not. Okay, so this is dream enactant behavior. It can be like laughing, talking, punching, kicking. Typically, it's the partner, the bed partner, who talks about this and tells me, I can't sleep with Joe anymore. I'm in the other room nowadays because just really can't sleep. This can be really severe. And in fact, I'm just going to show you this video here on the right here of a patient who's having restless leg. So this REM sleep behavior can be so severe that it can actually, you can injure yourself during sleep by punching or kicking at things. You can even fall out of bed and injure yourself as a result of this behavior. So it really needs to be recognized and treated. If you're not sure about it, again, I want to go back to that sleep study to really diagnose this disorder, okay? Again, this can be a risk factor, and onset can predate your symptoms. And often I get a story that patients may have had these symptoms for years and then it's starting to peter out, okay? All right. All right, so what should you do about this, okay? First of all, safety, 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 okay? So secure the bedroom and your partner. So if you're sleeping with someone like this, you may want to be in that other bedroom, okay? But make sure the person who's having the symptoms is safe. If you need rail on the bed to make sure they don't fall out of the bed, that's important. Pillows, other things that can, protect the patient who's having actually this behavior. Reduce medications or get rid of medications that might be causing this, and then try to treat. Melatonin, that drug I already mentioned for folks who have insomnia, can be a really good initial treatment for this. It's worth trying, but often patients need a higher dose than you see over the counter. So usually what you see is either 1 or 3 milligrams. Doses needed to treat REM sleep behavior are typically in the order of 10 to 20 milligrams nightly, okay? And if that doesn't work, we have to move to stronger drugs, such as what class of medications we call benzodiazepines. And one of the longer acting drugs is called clonazepam. This is a controlled substance, but it can help with anxiety and can help with this REM sleep behavior disorder as well. It's worth trying. Sometimes we have to use both and try other medications. Disordered sleep, so sleep apnea, big deal. In MSA, of course, is a big deal for many people actually, but quite common. Effectively treated with what's called CPAP, or continuous positive pressure on the airway. I'm going to just skip through just in the interest of time. Another feature of multiple system atrophy that's that needs to be watched out is for what's called respiratory stridor, that kind of breathing, okay? So sleep apnea is where a patient stops breathing for a period of time and their oxygen levels actually drop, okay? And that can happen multiple times at night. Stridor is actually high pitch, this inspiratory respiratory strain or restriction, okay, of the airway. And this is going to occur up to 15 to 40% of patients with MSA. And it can even be an initial manifestation of disease as well, okay? So if you're suspicious that your partner has this kind of breathing pattern, you need to let your doctors know, okay? Because this needs to be treated, okay? It can be treated. Typically, positive airway pressure is helpful for patients, but in severe cases, sometimes a tracheostomy is necessary, okay? And there are other alternative treatments listed here as well. There is such a thing called this floppy esophagus as well. That's where the back of the esophagus kind of can sort of track. And so this is another important feature to look out for, okay? Special mention should be given to this type of sleep apnea. So we talk about obstructive sleep apnea in multiple system atrophy. This can also be what we call a central issue, a brain issue. And this could be that the brain is sending the wrong signals to the breathing muscles, okay? So just like it can give the wrong signals to blood pressure centers and urinary centers can give the wrong signals in terms of breathing as well. And this sometimes requires a different form of breathing apparatus, what's called like a BiPAP, okay? So that's just a really quick overview of sleep issues. So I'm going to take questions. We'll all come back as a panel. I think what we're going to do right now is, sorry, this went over. Everyone take, what, 15? Yeah, take 15 minutes and then come back. We'll all be up here. We're going to go around the room and collect all of your questions and sift through them while you're doing that, okay? Thanks so much for your attention.